joined us on what is the last webinar of this current series, the last of 6, addressing the impact of the global pandemic on forensic services. Welcome to all of you. Thank you for those of you who are returning, who have been with us through this, and to anybody new who's joined us. Today is, as a final wrap-up, we're doing it slightly differently from previous times, and on this occasion we will have 5 panelists from across the world to reflect on their context and the lessons that we may take globally from the pandemic and the issues that will move forward from it. Just to orientate you to what we're doing, please consider completing the evaluation forms on the link that was attached to this meeting, and we will put that link up in the chat for you also. Without further ado, it's my pleasure to introduce the panel, and I will share my screen with you to allow you to see who our esteemed panelists are this morning, Toronto time, this afternoon, European time. In no particular order other than alphabetical, Professor Gary Chamowitz from Hamilton in Ontario is Professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster, and is Head of Service at the St. Joseph's Healthcare Forensic Psychiatric Program. Welcome, Gary. Second is Associate Professor Markku Eronen, who's Associate Professor of Forensic Psychiatry at both universities of Turku and at Helsinki, and is Medical Director of the Vaasa State Mental Hospital. Welcome, Markku, and you've been with us throughout the series. It's a pleasure to greet Professor Michael Norco, from Professor of Psychiatry from Yale, who's editor of the Journal of the American Academy of Psychiatry and Law, and a leader in that organization, and Director of Forensic Services in the Connecticut Department of Mental Health and Addiction Services. Welcome, Mike. Professor Lindsay Thompson is Medical Director of the State Hospitals Board for Scotland and the Forensic Mental Health Services Managed Care Network in Scotland. She's Professor of Forensic Psychiatry at the University of Edinburgh. Hi, Lindsay.
Thank you.
And finally, Associate Professor Lisbeth Erskov Sorensen, who's Senior Consultant and Research Leader in the Department of Forensic Psychiatry at Aarhus University in Denmark. Welcome, Lisbeth. Pleasure to have you speaking with us this morning.
Thank you.
What we will do through the next 90 minutes, and we will stay on for discussion following that, is address what we think are 3 core questions that have spanned the presentations that we've had over the course of the webinar. What have been the major impacts of COVID on your service? And we'll hear a little bit about each individual place, and what the pandemic has forced you to reconsider about the way you organize services. And finally, what have you learned at the intersection of science and expertise and social disadvantage in the public discourse, the kind of broader places of the pandemic on medicine, on psychiatry, on science in the public arena, and what lessons we may take from that. So those will be the things we will be discussing for the next 90 minutes. So question 1 is, what have been the major impacts of COVID on you and on your service? And to answer this, we will go east to west. And firstly, Markku from Finland and Scandinavia, your perspective from the eastern end of Scandinavia.
Okay, so hello everyone, and greetings from Vaasa, Finland. Vaasa is on the west coast of Finland, and we are only 60 kilometers from Sweden, and a little bit up from here, it's we share the border with Sweden. So we kind of have also a great effect also from the Swedish data, and I wanted to get some of that also. Well, First of all, it really had a major impact, and yet we have not had even one single positive case in our forensic system, not with the patients, nor with the nurses or other staff members, not in the prison forensic psychiatry, and not in our other forensic psychiatric hospital services. So we have been very, very lucky. There have been some cases in prison, in general prison, but they have been able to detect them very well, and so we have been very well protected, and we have been really shutting down things. We have done a lot, which you have heard from the previous sessions, the same things. I mean, taking care of the social distances, really washing our hands and doing that as much as we can, and everything else what you all have done. We have done that also. What has been very difficult for us is that we also didn't allow our patients to go, for example, to outside the hospital area, and that's a big thing in Finland. Even in the hospital where I work, even in the most closed ward, it's still possible that some of the patients can go to a nearby shop with a nurse, but that all stopped, and that was part of the treatment. So the attitudes towards moving us outside the hospital completely changed. We didn't allow any visitors to come, and that's also very strange for our system, because normally even the patients who are in the most closed wards, they are able to see some visitors. So that's a really, really big change. And in Finland, they even did something which may have been against our constitution. They actually said to Finnish citizens that we are not supposed to travel to southern part of Finland, where there were more infections compared to the other parts of Finland. And the people living in Helsinki area, there were actually police checks, and they said that, well, you shouldn't go there, and if you tried again and you didn't have a good reason, they gave a fine. And afterwards they realized that that was not legal. It was not legal to do that in Finland, so they canceled all the fines and said that, sorry, okay, we meant that you shouldn't go. That they kind of were not clear what was possible to do and what wasn't. Anyway, people were quite happy with our government. Maybe you know that we have all female leaders in our government, and it's we have been kind of proud to see those pictures from Finland, where there are those 4 ladies who are leading all the parties which are in our government, and one is approximately 50 and the other ones are around 30, and people think that they have done a good job, and it has been good advertisement for Finland, I think. Anyway, the changes have been really big, and now we have been opening the system, and we can see that the numbers generally in Finland, they have been rising. They are still very good. I mean, we only have a little bit more than 300 deaths, and for example, Sweden has 6,000 deaths. Okay, they have 9 million and we have 5.5 million population, but the difference is huge. So we are, in that way, we are satisfied. But now we have to deal how to, well, partly open and partly maybe close again some of the systems. We have just decided, well, Finland has decided that now they recommend everyone above 15 years old to wear a mask in the area where we have pandemic symptoms, where we have had symptoms within 2 weeks. If there are some areas in Finland where there has not been a single case in 2 weeks, you don't need to wear a mask. But otherwise, you need to wear a mask when you are in public transportation or in a place where you can't do the social distancing. We are now planning to test people who are going to come to Finland, and And I don't think that that's possible. We have people in northern part of Finland who share their homes, their jobs with the Swedes, and all the testing capacity would not be enough just to test these people who travel all the time between Sweden and Finland. So we don't know how it's going to be in practice, but this is how we have been doing so far. People have been okay. I know. Okay,
Margaret,
I finished. This is
a rigid chair, so we'll come back to more of that soon. The Danish experience, you're looked at from afar as having been very successful.
Yes, thank you very much. We have many similarities with Finland. We have no infected forensic psychiatric patients. Very few staff have been infected. We have also restricted leave for forensic psychiatric patients, and we have a female prime minister. We had a very strong lockdown in the beginning of March, and soon after, governmental bodies started pouring out regulations, and they turned into guidelines in the regions who run the hospitals. The CEO for our region declared that we should continue our usual outpatient activity. So that meant that we had to keep everything running, and we were expected to show up. Very few of the healthcare staff stayed at home. So that meant one of the impacts, and it was an eye-opener, was that the staff actually felt more empowered because we had to delegate very quickly and they had to make decisions on the fly. So that was a very good positive outcome. We also maintained in forensic psychiatry our outpatient activity. What we have seen, but we haven't, we think that our BBC scores and our registrations for threats and violence have decreased, and we intend to look into it once we are past the next months, but we think that it's a very good outcome also. Like other countries, we found that video is accepted, virtual meetings are acceptable for staffs and patients. We've found it hard to maintain our relevant rehabilitative activities and sustain hope among patients. That was it.
Thank you. To Scotland, to Lindsay Thompson.
Thank you, Sandy. I must admit, I'm not sure how this will carry for a North American context, but this is reminding me of the Eurovision Song Contest, where we now have, I'm not sure if I'm the entry or the scores from Scotland, but it's a little bit like that. But in terms of our experience here in forensic services in Scotland, of course, the effect of COVID has been profound. Very briefly, to describe our service, across the forensic network, we have 1 high secure, 3 medium secures, a variety of low secure hospitals, services in the community, and of course linked services into prisons and other areas of the criminal justice system. And the population of Scotland is just under 5.5 million, which will allow some comparisons. For example, the Danish population is very similar. To date, our deaths from COVID, confirmed deaths, is at 2,491. And I'm glad to say that it's been mid-July, I think, since our last death, and our R number is sitting between 0.6 and 1. So as I say, this has had a profound effect on us. Across the network as a whole, we have had COVID in high secure, 1 medium secure unit where there was 1 death, and 2 low secure units. I'm going to make my comments in terms of the experience largely based on our high secure hospital where I directly work. It has 120 beds across the network as a whole. We have 500 beds, but there's 120 beds in high security. And we have written up and submitted for publication the work that we have done to date. So from the 20th of March, that was our first positive result, we had 8 positive cases of COVID in our patients. I'm very pleased to say that no one required general hospital care and everybody has fully recovered. And our last case positive test was on the 6th of April. In terms of staff, we've had 9 positive staff tests, and again, everyone has recovered. And we continue to test where it is a new admission, pre and after admission, where anyone is symptomatic or where anyone is moving on from us. And staff, of course, are tested on the basis of any symptoms and on the basis of any contacts, as would anybody in the community be. So we had an outbreak of COVID within our high secure setting. And of course, the majority of people joining this session will be very familiar with psychiatric hospitals and the linking between patients, the mixing between patients, the socialization, the activities that we go for as part of our package of care creates, in essence, a hotbed essentially for the spread of this type of infection. And not only do we have the patients living together, but we also have all of our staff, about 620 in total, coming in and out of that setting. And I think in my initial comments, I want to remember how concerning it was at the start of all of this back in March, for how worried we were that we were going to see very widespread community infection. And at that time in the UK, they were talking about 80% of all of us getting the virus, that our National Health Service would be overwhelmed with cases of people requiring hospital care, intensive care treatment, and that our concern was that the virus would run through our patients, that they would be seriously ill, and we may not have access to services in general hospitals and intensive treatment units to provide the care for them. And that was our initial starting point in considering what services we had to set up. And I'll come back to that in later questions in describing actually what we did. But just to give you the main part just now of our response, it was firstly, as required by the National Health Service, we had to set up an incident command structure, which is no longer the discursive management structure of the usual health services, but I decide, if you're chief executive, or we decide at the different command meetings, it is done. So the speed of decision taking became much faster, very clear, clarity in communication. And our main clinical response was a major change to our clinical operational policy, whereby instead of a policy of activity, of mixing, of interaction, of therapeutic activity, we went for isolation with patients being kept in the room, except initially for 2 half-hour periods per day. We worked for those who could not tolerate this and set up individual care plans. Everybody got an individual care plan, but they had individual care plans that did not put them into that setting. And we set up a very detailed daily monitoring system of different matrices, such as incidents, self-harm, patient activity, access to fresh air, about 8 different monitoring measures that would allow us on a day-to-day basis to see how the model was going. And it was this balance between risk of infection to our patients, risk to their physical health, recognising the balance against their risk to their mental health, because that is not the traditional model of mental health care or forensic mental health care. So I'll stop there, Sandy, and let you move on, and I'll discuss more of the details as we come back to the other questions.
Yeah, there's much to, between what Lisbeth said about a reduction in aspects of self-harm and what you'll be able to measure, and violence issue and risk issues, and what you'll be able to track. So let's return to that. But next, can we hop over the Atlantic and go to a country more afflicted? Welcome Professor Norco from Connecticut. We've heard a bit from New York, from Jeff Metzner, from the correctional end in the US, how it has been, but your experience in Connecticut. would be very valuable to hear about. Welcome, Mike.
Thanks, Andy. So the first thing to recognize is that Connecticut, it was sort of right next to the original hotspot in the United States, New York City. And the virus spread to the most contiguous parts of Connecticut first, the southwestern portions, and then spread through the whole state. So we saw it progress across the state and into many of our facilities. So one of the first things that we had to deal with in our maximum security, we have 91 beds in a maximum security environment and 138 beds in a medium security environment. We had to figure out how to quarantine patients in a maximum security environment, which is sort of a rigidly structured place with not a lot of extra room. We wound up setting up an isolation ward in the gym at first because it was the easiest place to use where we could have space. Sometimes units would be quarantined so that there were no admission discharges from a unit, although we never stopped admissions per se. We never forbid them. They were able to relatively quickly use some space in our patient mall and set up a negative pressure space, and then that became our isolation ward. The spread was managed quite well. We had 10 cases in the hospital. About 4.5% of the population were positive for COVID. About the same percentage of our staff were positive. They, of course, were asked to quarantine at home. So we got through it relatively quickly in Connecticut. Our shutdown started on March 19th. Our deaths and hospitalization use all peaked around April 22nd. The last positive patient case that we've had in forensic services was early June. So they've been doing fairly well there. Another significant impact we had, though, is our relationship with the courts. So essentially, our courts just stopped doing business. The only thing that they would do were arraignments for major felonies and domestic violence cases, but all of our competency to stand trial hearings just stopped. So that meant that there were no admissions coming in once that happened. So we saw a dramatic decrease in admissions, and there was no way to hold hearings for people who were already in the hospital, who had been restored, who had court dates. So we had to set that up with the court system, and they were scrambling to try to create video conferencing technology. They had a sort of a vestigial system that was installed about 15 years ago. We had a way to connect to that. So did the Department of Corrections, but people didn't really use it. And over time, the technology became quite outdated and no one had used it. So everyone was scrambling to try to figure this out. And every case became an individual negotiation for how to set up an individual hearing. But we were able to, over the whole time period, we've been able to discharge 56 patients from the hospital, which of course was something that there was a lot of incentive to do, to get people out of a closed environment where social distancing was more difficult. So at the moment, the census on our admission units is actually quite small, and social distancing is fairly easy. What's been harder than even closing down has been reopening. So it's been hard to figure out how to do evaluations of people who were in custody for competency to stand trial mostly. There's a limited amount of video conferencing technology available in DOC, and it's being used largely for their own internal telehealth purposes. So they can't give us a lot of time with their equipment because it deprives their clients from getting needed psychiatric services. And we've had the same difficulty with doing evaluations in the community. Our offices tend to be small. psychiatric offices in general are small places where often there's just two people in the room, and we've had to try to figure out how to set up larger rooms and do video conferencing evaluations for the people who were not in custody, people out on bond or on promises to appear. And so we're just starting now to gather some experience doing that. We've done a couple of them outside of a building on a picnic table, but others we're trying to do using video conferencing technology and having people. We have 3-person teams that do these evaluations, and we're trying to do them with probably 2 people joining remotely with 1 person in the room with the defendant. So there have been a lot of things that we've had to figure out that we haven't been doing in prior to the COVID. So I'll stop there.
Okay, thank you. And to Canada, to Gary and Hamilton.
Thanks very much, Sandy. So let me just give you some perspective. We're in a mid-sized city on the western shore of Lake Ontario, about 70 kilometers from Toronto, but also 80 kilometers from one of the longest undefended borders in the world with the US. And as you probably know, Canada sits somewhere in the middle, actually, between the 5 of us sitting around the table in terms of COVID cases. So a little less than 50% of the cases in the US. So we were lucky here in Hamilton in terms of not having any COVID positive cases in our forensic program, but the impact on our program has been incredible. I've also reached out to some of the other programs across the country to see kind of what they've said about this as well. So we're an academic health science center, and I like to say almost like what a year this last week has been, what a week this last year has been. It's difficult to believe that the first case in Canada was in January, and we've evolved. So the impact of our service has evolved over time. Probably one of the major concerns that we've had and issues that we've had has been the issue of communication lines shifting and trust with leadership. Much like all of you, we had an incident management system, and decisions were made away from the clinical interface. And so a number of our clinicians felt quite concerned and out of sorts when their ability to impact decisions that they thought they normally would have with respect to patients were taken away from them. The other thing is because information was coming out from an incident management system that was somewhat divorced from the mental health and definitely from the forensic environment, people began not to trust what they were hearing. And as you can imagine, sitting in Canada, we are exposed to CNN and Fox News, so trust in leadership is probably at an all-time low. What we did was we ended up with a 3 p.m. radio show where a manager and myself got on sort of the radio internally, so to speak, and basically had told staff, you don't need to read your emails during the day. We'll give you an update at 3 o'clock. So we spent about 5 or 10 minutes, sometimes 15 minutes, doing a bit of Q&A and updating staff so they could focus on their work. That was helpful. We met with our physicians every morning by Zoom to keep people together. So communication and trust issues, I think, were major issues. The town-gown divide definitely increased. I'm a physician, obviously, but I'm also an academic, but the university essentially went on hiatus. So there was this tension between the clinicians or people who were in the hospital and the full-time academics who basically worked from home. And as you can imagine, when fear was dominant, that was an issue. We were also very lucky that most of our physicians were sort of connected with a video conferencing system. We have about 6 or 7 hardwired systems in our program. We were able to pivot very quickly to doing Zoom and video conferencing connections with our courts, with the jails, and in fact, even when things were at the height of the fear, we would sit in our offices and we would have team meetings from our offices, not going onto the wards, to limiting that. So the other thing I just want to touch on is this issue of the information we got from Central, or information we got out, because it seemed like science was influenced by supply, and people began absolutely not to trust what they were hearing. Eventually, and I think it's easy to look now, everybody's an expert. I think probably 2 months ago, we would have given every virologist, epidemiologist, and public health person the Nobel Prize. But at this point in time, and as we were saying earlier on, everybody has brushed up their science and everybody seems to have their own opinion on what's going on. So we've been lucky here in Hamilton. I think it'd be foolish to try and attribute that to things that we've done, because I think we just don't know what actually is going to happen with the next phase. But just one other thing about what's happened is, one of the things in Ontario, and you've probably heard, is we do have a very well-developed forensic directors group over the 10 or so forensic systems, and a very good relationship with the ministry. So if anything, we were able to pull together very quickly, and we would meet regularly across this province with all the forensic programs, getting information about what other people were doing and organizing that. So that served us really well, as did our well-established relationship with government. Thanks.
Thank you, Gary. There are lots of things that resonate with very different pieces across that. Thank you all. So 2 units who, like us, have had outbreaks within them, and there are obviously specific lessons in outbreak management, but the effect of restriction of movement, what impact that will have on us in terms of positive and negative pieces, I think are fascinating things to reflect on. Your themes, Gary, of holding together the teams and the importance of communication as well as clarity of direction come through. Could I ask you now to then think about the second question then? How has this, what you've done, caused you to reconsider about the way in which we organize services? And will that persist from henceforth? And to respond to this, we will change the batting order and begin with Lindsay in Scotland, then go to Lisbeth, Mike, Gary, and Marky. So Lindsay, could you lead us off on this one, please? You're muted all of a sudden.
Thank you, Sandy. You've unmuted me. Yes, so I was describing the model that we put in place to stop the spread of infection in Scotland. And the important thing to say is, of course, that has been very successful for us. So we had put in place this restrictive model with restricted patient movements. And we took a number of steps. Firstly, in establishing a monitoring group for the model to balance the risk, as I described earlier, between patients' physical and mental health. And we also established a scientific technical advisory group with colleagues from public health, infection control, and occupational health to advise us as we took steps to gradually change and release the restrictive model. And so through those 2 aspects, the monitoring and the scientific group, we have made significant changes to the model such that the patient's experience is now more focused on activity, certainly for those who have it on grounds access, on physical activity. One of the spin-offs of this is that patients are actually, and it's been measured, doing more physical activity in this period, and gradually bringing in some of our activities back, such as outdoor activities in the gardens and exercising, cycling, as well as some of the therapeutic activities, obviously individual sessions and some limited group work, but only small groups and patients on the same ward. So we have the scientific, we have the monitoring, we are gradually moving forward, releasing the isolated model. Patients are out of the room more. As of next week, we will have it that our wards, our 12-bedded wards, that 8 patients can be in the day areas at any one time. So yes, there has been change in how we've delivered, and we continue to be very cautious in terms of infection control, but it is moving forward. I should say that in that alarming period initially, we also set up all forms of medical services, from near-me consultations, video consultations. We stopped visits, but we brought in video visits for patients and their relatives and carers. We set up links with our local emergency department that would take us past the front desk if we needed to consult. We identified patients with relevant comorbidities, those who needed to be formally shielded. We created physical health summaries. We agreed with Scottish Government the exact mechanism to transfer patients to hospital. If they required this, those who were on what we call restriction orders and needed Scottish Government approval to do this. We obviously established very clear infection control guidelines. We have not had a problem with PPE, for which we are most fortunate, and that's probably related to our health board status. And we established very careful clinical care support documentation, how to assess, manage, treat, transfer, where appropriate, patients with COVID. And lastly, we established a general medical ward. And I can remember my relief, and it was Good Friday when we finally got the oxygen supply to that ward. But I'm very glad to say that we haven't needed that. So we've had our immediate response, we've had our scientific and monitoring response. We've also had very good links with Scottish Government, with initial weekly meetings across the forensic network as a whole to plot the effects that COVID was having on all of the different units and the responses to this. And through that, we have managed to re-establish some patient flow. We have always, across the board, been open to emergency admissions with the safety checks of testing that I described. But clearly, you will fill up quickly if you take in admissions and you can't transfer anyone out. In the last 2 to 3 weeks, we have begun the process of transferring out, again, with appropriate testing for COVID. That has been successful, high to medium, some medium to low. The big step is the community step, and we've still got issues to address there because you need facilities open for patients to be able to go to, and you need the accommodation available, which may well have been identified for individuals to move on to. So in terms of our overall patient flow, we've certainly a piece of work to do in terms of those moves to the community. So good links again with Scottish Government in terms of moving people forward. The speed of change has been remarkable. For example, in terms of technology, decision-making, changing models, all of these factors, and that is something that we would very much wish to see continue into the future. And lastly, I would mention our remobilization plan. We have followed the route map set out by Scottish Government, and to largely mirror that in the 4 phases that they've set out towards our recovery. As a country, we're currently in phase 3. We endeavour to mirror that, what we do in the high secure hospital setting. And there's been a large piece of work done on remobilisation, and a major piece of work led by our Chief Executive in May and June on consulting with the patients, the staff, carers, relatives right across the board in considering what temporary measures we put in place, what do we do about those, what have we brought in that's innovative, how do we amplify those, what have we identified that's obsolete and we should stop, and what have we paused and we should restart. And I'll stop there because that's probably take us to the third question that you've set us today.
Then Mark to Lisbeth.
Yes, thank you. I'll try and focus on basically 2 issues here, on major issues. In forensic psychiatry, we're very dependent on other sectors, other agencies. And when we continued our outpatient activity, the municipalities who do supportive home visit cancelled all their appointments. we realized that we had to change tactics. We had really increased virtual meetings and had decreased the personal meetings, but within 2 weeks we had to shift once again and go to personal meetings and home visits, which we try to decrease because it's municipality task basically. So because the municipality canceled all meetings, we had to shift rather quickly 2 weeks into the process. Later in the process, we have some coordination with the municipalities, but we have learned and have realized we have to consider the collaboration with other agencies, because otherwise it's hard to keep up the activity in a situation like this. We are uncertain if lengths of stay have increased during this process. We think it might have, but we're not entirely sure. We don't have many discharges per year. We only have 60 beds. So another thing is that we are the only region in the entire country who closed down on daily leaves. As in Finland, it's a big issue that you can go out shopping and go out of the hospital. So the other 4 regions continued to provide daily leaves, but as we were the only ones, we have had an internal debate. Was it right that we were so restrictive? We have no infected forensic psychiatric patients in the entire Denmark. So could we have done with less restrictions? The reason why the leadership in the department chose this was that we prioritized the ward and keeping the wards running, because if we had an infected patient, the patient would be transferred to somatic and we would have to send staff along. So we prioritized to keep the ward running, and we think we'll do that again if a second wave comes.
Thank you. Mike, what have you caused to reconsider, and how do you think that will impact change for your services? Unmute Mike, please.
Okay. Connecticut is a small state, so it's been relatively easy for us to travel around for meetings, to travel to various DOC facilities, to do evaluations, to different courts, to testify. So we never felt the urgency to develop a significant video conferencing capacity. And obviously the fact that we didn't have that put us in a difficult place when we had to go into shutdown mode. So we were not able to really respond very quickly or completely effectively. And this continues to limit the efficiency and the volume of our work. So as I mentioned earlier, we were just getting started doing evaluations of detainees in DOC facilities. But then the volume increased, and they were getting so many requests that they can no longer honor them because they just don't have enough video conferencing capacity. So now they're working on a protocol for people to come into the facilities and do evaluations in person. That involves people having to be tested and some other things, and they're still working that out. So our lack of a really robust video conferencing capability has limited our ability to respond. And I think one of the things that we've learned is that the video conferencing in many ways improves our efficiency. I mean, even though it's a small state, if you have to drive 45 minutes or an hour to get to a meeting, that takes up an hour that you could be doing other work. So I think there are things that we're going to carry forward into the post-COVID period, learning that telehealth and video conferencing meetings and telework can all function successfully and should probably be part of our future operations, although there would be complicated labor management issues to work out about telework. And there's some minimal discussion starting to take place about that, and the concerns that come up about, well, how do we know that people are actually working if they're not coming into the office? Another thing that's occurred to us, and it's occurred to many of my counterparts in other states, is just how much of a burden it is to restore people to competence who have been charged only with misdemeanor offenses. And everybody's interested in thinking about statutory remedies that might allow them to avoid putting people into forensic hospitals who are only charged with misdemeanors. Only New York State, as far as I know, has a statutory system for doing that. And we've been trying to think about how to figure this out for a long time, and it becomes complicated because it's a complicated system, and complex systems tend to achieve homeostasis. And even when you try to fix something, the change doesn't necessarily carry through. So we're still trying to think about that, and at the moment trying to figure out if there's a way that we can enhance our use of jail diversion in cases where competence has been raised. But I don't know how far we'll get with all of that. And that brings up the last thing that I'll mention, which is that all of this just highlights the challenge of having inadequate community treatment capacity, including housing and employment services. So if we had more of that, there'd be more opportunities for diversion. And we're in a fairly well-resourced state from that perspective, from a community mental health perspective, and still it's not enough to keep people from having to go into institutions, and the risks of that have just been amplified. Even though the hospital's kind of a safe place to be right now, in fact, probably safer than some communities, there's still the fear factor, right? Nobody wants to be locked up in a place they can't leave during a time of a pandemic. So that's another area that this is highlighted for us. Now I'll stop on this question there.
Yes, it's the rate at which we've been able to achieve some change has been remarkable through the pandemic, hasn't it? But then the more complex it becomes, changing legislative regimes or judicial practice. There's been much talk here about how the court should have gone virtual a long time ago, and very rapidly it's all moved, and what will that do to long-term court efficiency? But it's also demonstrated other major gaps, things we can't solve without addressing other holes in our services. Gary, your reflections on that from a Hamiltonian perspective?
Yeah, thanks, Sandy. And I think your expanded advert question said what's on your mind, and that's part of the question. So I'll just mention two things before I tell you what I think we should be doing, or what I hope we'll be doing. One is, I go back to that point in time where Italy had just been hit, and then New York was being hit. And I remember personally, there was a point in time where I was absolutely terrified. People around me were worried, physicians were worried, people I was seeing were worried. Given my age and one or two age-associated medical issues, I thought I was going to die. And I didn't know what I was, like in terms of the virus moving through Italy and New York. That didn't last a long time, but I have to go back to that time because it's easy sitting now and looking around. I remember seeing an advert in the Globe and Mail, or a headline that said, you can have an economy or you can have old people, but you can't have both. And that's kind of spoke to me. And I think, that's something we need to think about. The other thing that caught me as well was, you probably can get from my accent, I grew up in a country which was a bit of a, so I'd say that a bit of a fascist feel to it. And I remember when the edicts were coming out centrally, I felt that loss of control and the loss of a voice that actually weirdly resonated with some of the concerns I had about personal voice growing up in a country that was so otherwise affected. So some of the things that I think we've been thinking about is, and I'm sure all of you, is we talk about essential workers, but the question is, who is truly essential? And as you know, it's an interesting question, and I think we're going to struggle with who's really essential and what does that mean. And I think also, as as the budgets come down, I mean, not all of us can print money like the US, so the rest of us are going to have to pay the piper. And we're beginning to think about, what do we need? What do we need to continue on? And how are we going to get through financially? And that is an incredibly tough question that sooner or later we're going to have to face. So I'd say being positive about things. I mean, going forward, one of the things I'd like to do is reinforce our reporting structures and our communication structures. I work in a matrix model where I'm not, most of the physicians here are independent contractors, and we rely on relationships with other leadership on the administrative side. And I got to tell you, if you don't have those relationships, things disappear very quickly in times of pandemics. So looking forward, improving reporting structures, improving communication pathways, making sure those communication pathways don't end up with what is alert fatigue. I mean, people were sick of the multiple alerts from multiple people, multiple organizations telling us what to do, and figure out how we can build in clinical ascendancy or the clinical voice going forward. And probably the last thing I want to talk about about in this section is this idea of, I mean, many of you looking around here are academics who would otherwise travel. Like, I've gathered not one frequent flyer mile to my aeroplan, and I don't anticipate doing that. So I've been around for a while, and it's interesting how you get away with not going to conferences. But the thing that's coming through, though, is the absence of that connection, the people part. And how do we build that back into the system where people can actually have fun over and above work and do the sorts of things that we used to be able to get from interacting with colleagues? Zoom's great, but I got to tell you, it's the coffee breaks and those connections that bring meaning to what we do as well. So those are some of the things we're struggling with going forward, and I'll stop there. Thank you.
Thanks, Gary. Marku, can you wind up these reflections from your perspective?
Okay, I totally agree on that, what Gary you just said. And well, one thing which you haven't mentioned in those previous comments is well, that what the patients have commented, and well, in our system we have 2 patient representatives in our executive board. And so they are always over there. We have had this for a couple of years. And in the beginning, it was a little bit strange. And for example, people from the economics department, they said that, how can we explain these things? They are very complicated. And I said that, well, it doesn't matter. I mean, they don't need to understand everything. And they're actually public figures, and we can speak about them. And it has worked well. And what comes to the pandemic, it's so that it has been very valuable to have those patients over there. We got better direct information, and especially we get a better sense what the patients think. For example, when we wanted to loosen up the restrictions, it was actually so that the patients were more careful than we. Well, not. I am oversimplifying, but they were very careful. They said that, well, we don't need to hurry. Maybe we will wait 2 more weeks, and after that we will allow that and that. They just kind of raised the question that, what's the hurry? Because the patients, they wanted to be safe, and that was kind of important extra information from the patients. That they said that it's been good that they have known that there are no cases in the hospital, and that we are protecting the patients, and so that felt really important. Of course, there were obviously things that we thought, and afterwards you can say that it was crazy that patients were not allowed to go to a nearby shop, and all the staff visited the shops all the time, and then they got back to the hospital. If the patient was on a leave, which was an exception, it shouldn't have happened, but it might have happened. If the patient came back, he or she would have have to voluntarily guarantee himself or herself into his or her room, and there were no legal basis on that. But well, they didn't go to leaves, but well, somebody was on the leave before we made the decision, and so we had to take them back, and we postponed their coming back from the leaves. But at some point, they just had to come back to the hospital, and so anyway. But it was valuable to have the patients in the group, and perhaps we should have even more than in the task force for pandemic. Well, that was my extra point, but I want to comment you Gary, about the money thing, if you allow me. I just made a very quick calculation yesterday when they published that in Sweden the total nation has saved 10 billion euros because they have not closed down their country the way we have done. And well, we are relatively alike. Maybe they are a little bit richer country, but the differences are not that big. If they had done the same as we, they would have had maybe the amount of debt that we have per population, and that would mean that they have now had almost 6,000 dead, and we have 300, and so they might have had something like 600 deaths, and so approximately anyway, it's something like 5,000 lives would have been saved. And the price of those 500 lives is 10 billion euros. So if you count it, it's 200,000 per person for one life. If we would like to save the life of all the Finnish people, that would be a little bit more than 1 trillion euros. If we get all the money, everything Finland owns, we don't have 1 trillion, it's less. So this is not working this way. So this is, we will see how it goes, and finally it may be that Sweden has chosen the right way. I mean, we don't really know that. Okay, I end here.
Thank you. That's a fascinating way of thinking about it, and the stark contrast between Norway, Sweden, Finland, and Denmark has been remarkable in terms of the different approaches taken. Well, over the course of the pandemic, it will be interesting. We're nowhere near through this thing. It'll be interesting to see how that all develops.
Of course, it's not fair to do it that way, because there are so many things which change. I mean, there will be a vaccination, there will be a cure, and so on and so on. But that's just simplifying and just to make us think.
Yes, it's valuable. We've all, as I think people have commented, suddenly become epidemiologists. We all look at curves, we all look at infection rates, we listen to epidemiologists on our nightly news, and public health specialists who certainly in Ontario and in many other places were being written off as being of little use in modern times. It's been quite a change in the place of science, of expertise in the public discourse. And how do you think that has changed the way in which we think of, Mike's already mentioned the issues of social disadvantage, the way we're handicapped in making positive changes in infection control because of lack of community services and the problems within our community. So we'd really like to invite each of you to reflect on those themes in the final questions. And Mike, can we begin with you in Connecticut to reflect on those points?
Sure. One of the first things that's occurred to me during our attempts to respond to the pandemic has been what an awful burden mass incarceration is on individuals, on families, on communities, but also on us as a society. You know, our Department of Correction was under a tremendous amount of pressure to get people out of the prisons, and over a couple of month period did a tremendous job of getting a lot of people out, which is a good thing. But then it makes you realize if it were possible within 2 months to get that many people out, why did we have to have them in to begin with? And that concept is also obviously related to racial inequities, and the pandemic has also highlighted those. the health inequities for minorities, for impoverished peoples, for underserved populations, for people living in communities with more crowded housing. As we were going through the stages of our crisis period in April, it became clear that many of the people, in fact, most of the people who were being hospitalized, who were in ICUs, who were on ventilators, were coming from poor neighborhoods, from places where people couldn't socially distance. And so all of those health inequities have also been highlighted in this process. And it gives us pause to have to think about, well, you know, we really need to think about this in preparation for the next pandemic, but just in terms of doing what's right for people. And the other thing that I'll just comment on is the challenge of public policy making when the empiric data are limited, incomplete, don't resolve all of the questions that we have. And so because we don't really know what the right thing to do is, it becomes really hard to make decisions. And so I'll just illustrate this with one example. As I mentioned, our Department of Correction is trying to create a protocol for how they'll allow our staff to go in and do evaluations in their facilities. And one of the things they're going to ask of us is that we test everyone at least once before they're allowed to go in. So, you know, I understand, you know, the political aspect of that, politics with a small p in this case. Because, you know, if something goes wrong, if there's an outbreak, you know, and there's questions, you want to be able to say, well, we did this, this, and this. But from a scientific perspective, the fact that somebody got tested on July 16th once doesn't mean anything about their status today. In fact, if they got tested yesterday, it doesn't mean anything about their status today in terms of their infectivity. So it's a challenging position. You know, the dynamics of this virus don't match up well with our need to establish good public policy, and it makes people anxious, and they make decisions that are not necessarily grounded in science, but we just don't have the science to back up everything that we need to decide at this point. So it's a challenging situation, and will continue to be so until there's a vaccine, I presume. So I'll stop there.
Thank you. Gary? So we need to unmute you.
Thank you. So this has been obviously a fascinating time, and there are clearly some things I've reflected on that I think for me have been very important. First of all, I think, and this goes back to about 20 years ago, I was looking up something about confidentiality, and I remember a law group in the States saying, you know, the aim is ignoring the dirty secret that there's no such thing as doctor-patient confidentiality, right? That was like 20 years ago. I think what this virus has done, and the pandemic has done, is shaken off the pretense that the clinical voice is the preeminent voice in healthcare systems. The other thing that it's also done is, notwithstanding the fact that the virus does not respond to political proclamations, the idea that science is speaking the loudest within our policy structures is also, I think, a pretense. As you know, I mean, politicians are not following science in general, notwithstanding what we think is going on. So I think, and again, I looked at a paper where I think in Nature they were looking at all the articles that have been written in the last short while. Most of them are done in predatory journals. So the science and the rapid science that's coming out under the guise of science right now, the speed with which things are being published today under the guise of getting the stuff out is not compatible with timely peer review. So I think science has been contaminated and continues to be contaminated at this point. One of the other things that I've really been worried about and concerned about, and I think we all need to think about this, is this tremendous shift to populism and self-interest and group thinking. And I am worried about this idea that physicians, key physicians, have been co-opted by governments in promoting, and I know this is the pandemic, and it's not some of the other isms that have affected the world in the last century and beyond. So I'm really concerned about the rise of populism and the groups of physicians that have gone along with government speak, which may be contrary to what we would consider liberal democracy. The other thing that, one of the things that has shown though is this recognition who actually speaks for patients. And clearly, I mean, with Ebola, with hemorrhagic fever, it's been, and SARS, it was a time when people were scared and you knew who stepped forward and who stepped back. So it's been actually fascinating and wonderful to see who actually is speaking for patients. I mean, and I think one of the things we need to think about then is, you know, as we go forward, who is there for the patients? And who will be there for our patients as we move forward through this pandemic and beyond? Because I think, in my view, we're with this for a while. So I think it's been really fortunate to be with this wonderful community of people. I think what you guys have pulled together here with this community of people gives me some hope. But I think I think it does mean that we're going to have to dig deep and get out of our science and get out of the politics of this and think more broadly about meanings of liberal democracy and speaking for patients and egalitarian healthcare systems. So I think we've got a challenge, but I'm worried, but I'm also optimistic at the same time. Thank you.
Thanks, Gary. Lisbeth, in New Zealand, it was said that they succeeded because of empathic leadership that also happened to be female, clarity of communication and consistency, and a strong sense of the country moving together. When you talk, I get the sense that those things are kind of givens within Denmark, and that's been part of your success. I'm not sure how you approach these questions.
I agree with you. Like Finland, we have seen inequality in health. It has affected certain socioeconomic and ethnic groups. But when this is said, Statistics Denmark have calculated that the COVID pandemic has not affected overall mortality in Denmark for the period of the pandemic. We've had 600 deaths, but it's highly estimated because if you were infected with the corona and you were hit by a car and died, you would be calculated as dying from corona. So the number of 1,600 is high. We've also seen, like Gary mentioned, the interplay between important leading doctors and politicians, and currently we have a great fallout on that. What I'll say is that we've had no public discourse concerning forensic psychiatric patients and the COVID-19. We had, as you're saying, Sandy, a very strong nation building by the Prime Minister. And then we began to discuss, right, we have to protect young ones. We have to protect elderly people because they sort of gave us our life. And then came the healthcare staff, and then came the companies, the economics. We locked down Denmark for one reason, which was very clearly explained, that we had to protect the hospitals. The hospitals had to be able to keep running and keep up with the flow of infected people. So we wanted to flatten the curve like everybody else. So everybody understood, or at least the message was to preserve the welfare state. So the focus was on important groups in the welfare state: young people, old people, healthcare staff, and those paying it. So there were no focus on FP patients, and I must say this is observational. So considerable funding were made for research, but none were earmarked for forensic psychiatry. A few projects were made in general psychiatry. So I think that nationally, this means that there's been no voice for forensic psychiatric patients, and we have no idea of the disadvantages and needs for forensic psychiatric patients, and it's not been measured. So you could say that forensic psychiatric patients have been marginalized in this process. Locally, we have followed the same guidelines as everyone else in the country, in the general psychiatry, in the somatic, basically. The staff at this department has requested that we had something more targeted to forensic psychiatry, and that we had discussed our own needs and the patient's needs in more detail. And a lot of the staff expressed that we had more patient information than patient involvement. So we did not, like the finish, have a great debate with the patients.
Thank you. Marco, leading on to you. Want to continue those themes and reflections?
Yeah. Well, one thing which was very unclear in Finland was what is the role of the experts, and what is the role of the politicians, and what is the role of the state, and what is the role of local officers. This has not been clear, especially in the beginning. We got instructions which were unclear, and they were even contradictory, and so it was very difficult to follow. To try, you try to do the right thing, but since you didn't know, and everyone were also a little bit afraid what is going to happen, and there was not enough information. Testing was not actually available. You were told that you just ask information from your local officers, then when you ask, they just give you the paper, which is just what we already know. So it was just about impossible to find information. And so, well, what we did was that, well, we, of course, we made our own pandemic task group, and we took their multidisciplinary people, I mean, people from the economy parts, I mean, people who is responsible for cleaning, people who are responsible for laboratory testing, and so on. And we had, in the beginning, we had meetings 2 times a week, and we kept a really good record on these meetings, and so we were able to kind of prove what are the basis of our decisions, and that I would recommend that if someone hasn't done this, so I think that's important, because now the legal guys are coming and they are saying that, well, why didn't you do that and that and that? Because the law says that and that, and so we can at least say that this was how we decided what we did. But well, what can I say? What we learned about it? I mean, we learned that it's absolutely necessary to have people from different groups, and as I already mentioned, the patients. Maybe we even take the patients more to the task force in the future now, because we are expecting that this is really not over. The second wave is coming, I'm afraid.
Yes, indeed.
Okay, thank you.
Thank you. Lindsay, final thoughts and reflections from you.
I think I'm going to take a slightly more optimistic perspective with regards to science and expertise. I think it's firmly back on the public agenda when something of this nature occurs. Even though there may be doubt, even though there may be academic debate, at the end of the day, you need people who have studied this, who have knowledge, and who can express that knowledge. And I don't know if it's different in systems or in countries or what it is, but I would say that the position of science and experts is stronger after all of this. I heard early on some of the comments had science been diverted by availability. So, for example, we see marked change in our PPE requirements now than initially. And was that because people didn't know, it didn't have it available, so you couldn't recommend it? I think the science has genuinely moved on over this, and I think sometimes political need to respond moved quicker than the science. So some of the debates early on about masks or no masks, I think the political need to respond outstripped some of the knowledge that was there. So I'm going to take, in our Trumpian era where all experts talk knowledge and you put it all in the bin, I'm going to take a much more positive view on where science sits in this and ethics. I also think, ever the optimist, that the public understand the concept of uncertainty, that in fact there may not be a right or wrong answer at any one point, and that it is more sophisticated, and as you get it every single day in your news, so I think some of that will become more and more evident to people. So that's science. Next area I would like to bring up is ethics, because I think a lot of the issues that are coming up in this last section are highly ethical. The financial breakdown Marco gave us absolutely fascinating. I think you came to the conclusion it was €200,000 per life. Now, in some of the procedures and cancer treatments that we utilise, that's a pretty normal sum of money. It was the scale of this. And we have the very interesting position of Sweden against I would take New Zealand and the Prime Minister's view that, you know, she wanted absolute lockdown and no one life was worth losing over this, regardless of the cost. What will come out in time forward are the opportunity costs. So we're beginning to see who has been dying in excess of other things that they might not have died of if we hadn't have gone into lockdown. And so we have unintended effects of the lockdown that most countries have gone through, and the ethics of what is the better way forward. You know, who's going to say to someone with a very ill relative, that person, we're not going to save them because of the cost. So I think there will be a huge ethical debate, and I'm surprised we haven't seen more of it. I think we're all so relieved that we didn't get swamped, and we thought we were going to have to make ethical decisions about who got treatment, who didn't. And because that hasn't happened, some of the larger ethical debates, I think, will take place later on, where we look at what were the responses and what did more good or what did not. Just on the forensic patients then, and the advocacy, and picking up the point made earlier about the courts and the prisons, interestingly, a lot of our patients, we've had a good few examples highlighted to us across the network, where people have been bailed that ordinarily we would have assessed and would have come to us. So we expect to see a degree of pickup in the months to come of these patients, because the court's response was keep everybody out of any form of custody if at all possible. Forensic patients, in terms of advocacy, that's clearly our job. We've had the good links with Scottish Government. The big issue, which many of us will have published on, is the health inequalities, which are writ so large for these individuals in terms of loss of life, poor social outcomes, doing not bad in terms of risk and mental health, but whole quality of life issues. And that's an overall advocacy issue. And the last one I want to bring is just, where are we going? I think Marco mentioned a second wave. We don't know yet, but it seems perfectly possible. We're going to have it complicated any way you look at it by winter viruses. So is this or is this not COVID? We've got the additional complication in the UK of Brexit, which is a difficult one at any point, but the financial and organisational implications of that at this point are extremely difficult. And over and above, I think our staff and indeed our patients have been absolutely remarkable through all of this, but I do worry about fatigue. And so listening and communicating, because people are getting very tired. I think tired personally of what's happening in their own lives, and the uncertainty, some of the immediate anxieties about, are people going to die that we're responsible for, that may have settled, the systems have been put in place. But I worry about fatigue as we go on into the winter months.
I just wind the conversation up there. That was a fantastically rich reflection, and there are multiple things that have just been said that need further discussion. Distributive ethics, unmet need that has been put off. Was that need that we needed to meet in the way we were? How do we address the income disparities in the unequal societies, the mass incarcerations, the structural racism, so much that this has thrown up about the well-being of our patients and our staff. Thank you to all 5 of our panelists. That was a wonderful discussion to listen and take in. I'd like to invite Harry Kennedy to provide us with some final reflections and comments before we wind up this session, and then we will open the floor at 10:30 to any comments and discussion that you might want to continue to bring if you're able to stay on the line. Harry.
Thank you very much, Sandy, and thank you very much to Michael and Gary and Elizabeth, Lindsay and Marco for really a very inspiring panel for the 6th of this cycle of webinars about COVID and forensic psychiatry. The themes that I hear actually, which reflect back onto our existence as forensic psychiatrists and forensic psychiatry services for patients, really, it seems to me it's about leadership. We've spent a lot of time talking about having had leaders who rose to the occasion. Very often, the most successful, we've been saying, were women leaders. We actually had a doctor in place as our leader here. And of course, the elements of that reflect back on what we have been doing within our own services, because noticeably, people who've tuned in here every week, every fortnight, have on the whole been clinical directors, senior clinicians, who are bringing our colleagues along with us. So very early on in all of this, I remember the example of a cruise ship with hundreds of people on it, left going round and round in circles because no one would have it, while the virus raged through everybody on the ship. Tragic, awful metaphor, and in a very concrete way, that immediately alerted lots of people in forensic psychiatry to what a secure hospital might turn into. And perhaps it's one of the things that helped us take quite extreme moves early on, stopping visitors coming in, stopping patients going out, screening our own staff every day as we came in and out, whether that screen actually had any real sensitivity or specificity or not. The leadership that we have been exercising, which I think Gary Shamovitz described very eloquently, depends totally on trust, doesn't it? And trust there's this equation for it. It's your credibility divided by the extent to which people see you as self-interested. And insofar as we are interested in our patients, not ourselves, our credibility goes up and up. And it's your credibility that enables you to move people with you. When you say to people, we want you to do this really difficult thing, we want you to take risks, be twice as scrupulous, wash your hands every 2 hours, wear these awful masks that nobody likes wearing. Your power to persuade people depends on this curious distinction. We're doing this for the patients, doing it for you, and it has credibility. The return of scientific influence in policy, I think, has to be real. I do fear that it will be gone 10 minutes after the vaccine program succeeds, but I hope that's not the case. I think we have to be optimistic that it isn't, and I think we have to assert that. In a funny way, what has happened is that the socializing of psychiatry and medicine has given way, in a very interesting way, to the medicalizing of psychiatry, at least for the time being, and perhaps with some long-term benefits. I could go on and on about this. I think the message for us is that we're perhaps a third of the way through all of this. when vaccines become available, credibility will come into this again. Would you have the Sputnik vaccine or would you have the Oxford vaccine? Why is the answer to that so obvious? A lot of it does have to do with this concept of credibility, where the credibility is based on the strength of science and the disinterested nature of science, the lack of bias. That's what we offer to our patients ultimately. There's a terrific field. There's a certain amount of time left. Can I welcome everybody? There are a lot of people I see on today that we don't always see. Mike Doyle, who is probably the leading academic nurse in our field. I'm delighted to see Mike online here at the moment. Debbie Bull, who is one of the commissioners for Forensic Services for England. Delighted to see you here as well. This has been a very successful series of these webinars. I hope that we can carry this forward in the autumn on more general themes. I'm going to stop rabbiting on and hand back to Sandy, who is such an able chair, to see if you can coordinate questions from the floor.
Just my final comments would be to thank the other members of the organizing group, Damien, Samita, Trina, who I think are all on, and Mary, Deborah, you've got your camera off, but you are there, who have worked with us on this. I commented, I think Gary mentioned that we can't meet right now. That's what this was about to a considerable degree. We can't meet, so let's meet and let's use this. We're very hopeful that going forward we'll find topics and ways of using this type of format to explore particular issues in more depth. I've written down half a dozen topics as we've talked today, not pandemic related, but more broadly in relation to our practice, that bringing this type of discussion to will be of great value. So maybe one of the benefits is our ability to meet in this way. It's clearly going to be another 18 months probably before we meet in person over a cup of coffee or a beer at conferences. So let us continue to meet in this way. And thank you to Melina and to Caroline, who have been at both Toronto and at Dublin, have been hugely helpful with this. So let us now, Melina, if you could, unmute people.